Well, welcome everyone. I wonder, Sarah, do we have enough people? Do we have quorum?
I think we might be missing a couple board members, but I feel like we have a lot to talk about, so you may want to get started.
Yeah, we don't want to move too long. Mike can't make it till 9:30, right?
Yep.
So I think we have enough to get started. Oh, good. Okay. All right. Well, welcome everyone. This is our second quarter meeting. A lot on the agenda today, so we'll kind of try to keep moving. I wonder, Sarah, if you could pull up that introduction slide. I don't have that ready. Sorry. We have a standard introduction because this is a public meeting that is being recorded. It's held virtually and hosted by the Utah Department of Health and Human Services Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah Open Meeting Code and posted on the Utah Public Notice website. The purpose of the board is to review the available research and literature and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for the treatment of certain medical conditions identified as qualifying medical conditions. It's being recorded, as I said. It will be posted on the public notice website within 3 business days, and written minutes will also be prepared from the meeting, and then approved minutes will be posted on the Utah Public Notice website after the board approves it. So that's one of our first items of business today, is to approve last meeting's minutes, right? Okay, board members.
It's kind of cool. I haven't gotten to be on this meeting before.
So, board members, I'm present. Mike will be here at 9:30. Misty, I don't know if we have Misty yet. Is she absent today? Russ is here and Melissa Chan is here. And then deputy staff or DHSS staff. We have more than this listed there, right, Sarah? We have more attendees from the DHSS today.
Yep. Yeah, we have a couple more today.
Great. Awesome. Well, welcome you guys. And was there one more slide about, yeah, public comment. So we ask that you put yourselves on mute until speaking. At the public comment period, we'll have 2 minutes given to everyone to make a comment. Select the raise your hand function so that we can go in order and state your name. And if you have any affiliation or any well-employed bias or etc. with any seller or producer or anything like that, and then state your question or comment. Our public comment is at the end of the meeting. Comments are limited to 2 minutes per person. Our board will hold their responses till after the comment period and then make any responses. As a courtesy to everyone, please place yourself on mute. Board motions and votes will be recorded in the minutes. We will now turn to the agenda. Okay. So we'll start with the minutes from the January meeting. Oh, Misty's here. Oh, good. Okay, we've got almost everyone. So I hope all of you, Sarah sent out a bunch of documents last week to reviewed for today's meeting. I hope you all had a chance to review the minutes. As a reminder, we discussed ulcerative colitis and Crohn's document, and we had some board training. We also discussed the patient assessment or screening tool, which we're going to talk about and maybe hopefully finalize today. And the memo to the advisory board, education updates, and public comments. So first of all, I would call for any amendments or discussion about the minutes. Okay, so if there's no discussion or proposed amendments to the minutes, I will call for a motion to approve the minutes.
I'll move to approve the minutes.
All right, do we have a second?
I'll second.
All right, Misty and Rush. Motion and second. Before vote, we have to call for one more discussion. Is there any discussion required before a vote? Hearing none, I will then proceed with the motion to approve January's minutes. All in favor, please indicate. All right, any opposed? All right, looks like we had a majority, and so the motion passes. The minutes are approved. Okay. Now we get to the meat of the meeting. I'm really excited. This is a big document that Lauren has prepared on muscle spasms and spasticity. Very thorough, Lauren. I was overwhelmed reading it. I know that a lot of work went into
Sorry
that.
about that.
At least you have my vote. Okay, so we'll turn the time over to Lauren to present her research and presentation. Take it away, Lauren.
All right. Sarah, is it okay if I share my screen?
Yep.
Okay. Oh, I can't share.
Let me see if I can change that. It says all participants should be able to, so maybe give it another try. If not, I have it ready as well.
Oh, yep, it's working now.
Okay.
All right, so you should see the slides. Hi, everyone. I'm Lauren. I'm a pharmacist working with the Center for Medical Cannabis, and today's presentation is an overview of experimental evidence for the treatment of spasticity or spasms with cannabis or cannabinoid-based products. The purpose of this review is to summarize clinical evidence relevant to the treatment of the qualifying condition of persistent and debilitating muscle spasms with cannabis, which has not been formally addressed by the Utah Cannabis Research Review Board, or CRRB. In consultation with the CRRB, we decided to primarily focus on studies of patients with spasticity associated with conditions other than multiple sclerosis or MS, since treatment of MS was recently addressed separately. I searched for systematic reviews of experimental trials, abbreviated ETs. Included experimental trials were randomized or non-randomized clinical trials that reported a spasticity outcome in any population other than primarily among patients with MS, or a spasms efficacy outcome among patients with upper motor neuron syndrome. Studies had to be primarily comprised of patients without MS or to report spasticity or spasm efficacy results for patients without MS separately. I extracted spasm or spasticity efficacy outcomes and any safety outcomes from ETs that studied any type of cannabis or cannabinoid intervention. From the literature searches and reviews of publications included by the systematic reviews, 14 trials that reported a spasticity outcome were identified, of which 10 trials were included. 3 trials were excluded from formal review because most patients had MS, and an abstract that I could not find a copy of was excluded. Of the 10 included trials, 6 were comprised of patients with spinal cord injury, abbreviated SCI, or spinal cord disease, abbreviated SCD, or included mixed populations with the majority of patients having SCI. The remaining trials comprised adults who suffered a stroke or who had amyotrophic lateral sclerosis, abbreviated ALS, or primary lateral sclerosis, abbreviated PLS, or children with various neurological disorders, with cerebral palsy being the most common. While all 10 included trials have limitations, as all research does, I flagged 6 trials as having limitations due to generalizability or study validity concerns, which I'll discuss further in the coming slides. This table summarizes the study design, patient population, and approximate duration of the 6 trials of patients with SCI or SCD. Trials other than the blinded crossover RCT by Puyania et al. Were considered to have limitations. Trials by Hagenbach et al., Kogel et al., and Maurer et al. Primarily had study design or conduct concerns, including failed randomization and use of a within-patient statistical comparison from different treatment periods for Hagenbach et al., an unclear study design that was probably a non-randomized before and after study by Kogel et al., and the use of a double-blinded N of 1 trial for Maurer et al. The Wilsey et al. Blinded crossover RCT and Jazz Pharmaceuticals unpublished blinded parallel group RCT were considered to have limitations primarily because they enrolled patients based on having at least moderate neuropathic pain, not spasticity. These trials primarily included patients with SCI or SCD who were quadra or paraplegic and seemed to have had moderate to severe spasticity, but details about spasticity severity at baseline were not reported by 3 of the trials. Hagenbach et al. Was the only trial that required patients to taper and discontinue any other antispastic medications before the trial. Other trials allowed patients to continue most other treatments as long as they were stable. Sample sizes range from 1 to 116 total participants, and the treatment durations were short-term, ranging from a single day with the outcome 7 hours after the first cannabis dose for the Wilsey et al. Trial to about 6 weeks. The N of 1 trial by Maurer et al. Randomized the patient to 18 sequences of 3 different treatments over a 5-month period. This is a visual summary of the spasticity or spasm efficacy results from the 4 trials that selected patients for having spasticity at baseline. Green indicates a statistically significant finding favoring the studied cannabinoid. Blue indicates mixed descriptive results, and red indicates a lack of statistically significant difference between the studied cannabinoid and the comparator. Puyania et al. Achieved their primary outcome, finding that nabilone 0.5 to 1 milligrams daily significantly reduced spasticity of the most involved muscle group on the clinician-assessed Ashworth spasticity scale compared to placebo. However, changes in spasticity on the patient-reported numerical rating scale and changes in spasm frequency were not significantly different from placebo. Hagenbach et al. Found significant within-patient reductions in spasticity from baseline per the clinician-assessed modified Ashworth scale that was summed for 6 different joints with a mean dose of 31 milligrams of dronabinol, compared to when those same participants received placebo. Results tended to not be statistically significant for spasticity measured on a numeric rating scale. Similar results for within-patient changes from baseline and spasticity were observed between oral dronabinol and the THC hemisuccinate and the 5 patients that received both dosage forms. Descriptively, Kogel et al. Found dronabinol at a dose of 10 to 60 milligrams daily reduced knee spasticity per the pendulum drop test relaxation index score by a mild to moderate amount in 2 of the patients, whereas spasticity was unchanged, worsened, or varied after dronabinol treatment in the 3 other patients. Maurer et al. Found patient-reported spasticity on a numeric rating scale significantly improved at all 4 assessed time points during treatment with THC 5 milligrams orally compared to codeine or to placebo. Regarding the 2 trials that selected patients for neuropathic pain, Wilsey et al. Found the lowest dosage of vaporized cannabis significantly reduced patient-reported spasticity on a numeric rating scale at 7 hours, but not earlier time points compared to placebo, among the subset of patients with spasticity at baseline. Significant benefits favoring the lower cannabis dosage were also observed on the patient's global impression of change. The unpublished trial by Jazz Pharmaceuticals failed to find a significant benefit of nabiximols compared to placebo for changes from baseline in spasticity or spasm frequency using various outcome measurements. Safety outcome details were poorly reported by many of the trials, but common adverse events associated with nabilone were drowsiness, asthenia, and mild vertigo. And the 3 trials that used THC dronabinol or THC hemisuccinate rectally, THC was generally associated with fatigue, increased or decreased anger, dry mouth, anxiety, and dysphoria. In the trial by Hagenbach et al., 23% of participants that received oral THC reported increased pain, of which 4 of those 5 patients discontinued the treatment due to pain. Patients in those trials also discontinued treatment due to anxiety, decreased attention or mood, and apoplexy. Any adverse event was reported by 82% of participants that received nabiximols compared to 48% of patients that received placebo. And serious adverse events were also slightly more common in the nabiximols arm compared to placebo arm. Common adverse events that occurred numerically more frequently with nabiximols than placebo were nausea, upper respiratory tract infections, dizziness, dysgeusia, and somnolence. During the single day of treatment with vaporized cannabis with 2.9% or 6.7% THC, no serious adverse events or discontinuations due to adverse events occurred. 1 patient experienced syncope that resolved without sequelae. When available, I extracted the risk of bias, abbreviated ROB, or quality assessment ratings for included trials that were performed by a systematic review, abbreviated SR. None of the 4 trials were assessed as being at a low risk of bias or being of high quality. 2 trials were considered to have some concerns or an unclear risk of bias. 1 trial was considered to be of poor quality and the other of fair quality. The 2 trials without a quality or bias assessment by an SR were the N of 1 trial by Maurer et al. And the unpublished RCT by Jazz Pharmaceuticals. All right, so moving on to a different disease state. The Riva et al. Trial was a double-blinded parallel group phase 2 RCT that included 59 adult patients with presumed ALS or PLS and moderate spasticity in at least 2 muscle groups, and had a treatment duration of 6 weeks. Marinelli et al. Conducted a double-blinded crossover trial among 41 adults with moderate or mild to moderate spasticity of at least 1 muscle group who had suffered an ischemic or hemorrhagic stroke at least 3 months before the trial and who had an acceptable cardiovascular profile. The treatment duration was 4 weeks, and both trials allowed patients to continue antispastic medications or regimens at a stable dose or intensity. The Riva et al. Trial among adults with ALS or PLS met its primary outcome, showing that nabiximols significantly reduced summed mean spasticity scores for multiple muscle groups on the modified Ashworth scale compared to placebo at 6 weeks. Significant differences compared to placebo were also observed using the patient's global impression of change, but not for the other outcomes of change in patient-reported spasticity or spasm frequency on numeric rating scales, or the caregiver's or neurologist's global impression of change. Marinelli et al. Found nabiximols did not significantly improve either co-primary outcomes of change in mean spasticity on a numeric rating scale or change in stretched flexes per electromyographic recording versus placebo, nor were significant improvements versus placebo observed for other spasticity or spasms outcomes among the adults who had had a stroke. Among adults with ALS or PLS, a numerically greater incidence of any adverse event was observed with the self-titrated nabiximols compared to placebo. Most adverse events were mild to moderate severity, with the most common adverse events being asthenia, somnolence, vertigo, and nausea. 2 patients temporarily discontinued nabiximols due to anxiety and nausea, but they were able to restart treatment. Authors of the Riva et al. Trial noted that the incidence of adverse events was greater during the blinded study period than during the trial's open label extension period among people who received nabiximols in both treatment periods, possibly suggesting that many of the adverse events occurred during the nabiximols dose up titration. In the Marinelli et al. Trial among patients with a history of stroke, nabiximols treatment was associated with confusion and dizziness. 2 serious adverse events occurred, with only one of those events of nausea being considered drug-related. Investigators did not observe any adverse cardiovascular events, leading them to conclude that 4 weeks of treatment with nabiximols had an acceptable cardiovascular profile in their population of patients with stroke who had passed the somewhat rigorous cardiovascular screening at baseline. A bias assessment by SR was available for the Riva et al. Trial only, and SR authors considered the Riva et al. Trial to have a low risk of bias on all assessed Cochrane domains for RCTs. The double-blind crossover pilot trial by Marinelli et al. I informally noted that they were at least at a risk of bias from insufficient randomization because they did not report enough details to assess those methods, and from high attrition rates during the trial. Regarding the final 2 trials, Fairhurst et al. Was a blinded parallel group RCT among children 8 years of age or older with moderate to severe spasticity associated with cerebral palsy or a non-progressive central nervous system injury. Patients were required to have an inadequate response to at least 1 year of treatment with an antispastic medication before entering the trial. A total of 72 patients were included, with 89% of patients having cerebral palsy. The treatment duration was 12 weeks. And the second trial by Libson et al. Was considered to have limitations due to insufficiently reporting of the study design, the lack of non-cannabinoid control group, the fact that patients could have had dystonia in addition to spasticity as the primary symptom at baseline, and because investigators possibly allowed for changes to other antispastic medications during the clinical trial. The Libson et al. Trial was likely a non-randomized before and after trial, and it included 25 children with a complex motor disorder who could be as young as 1 year old. Most participants had cerebral palsy, and the mean baseline spasticity severity in the total population appeared to be high at baseline, with a mean score of 8.29 out of an unknown total possible score. Fairhurst et al. Failed to demonstrate a significant difference between the caregiver titrated nabiximols and placebo for the primary outcome of change from baseline in caregiver assessed spasticity on a numeric rating scale. Significant differences between the treatment groups were also not observed for secondary spasticity outcomes, including the changes in the clinician-assessed modified Ashworth scale for multiple muscle groups and the maximal muscle reading on the modified Tardo scale. The Libson et al. Trial found that the 2 different doses of CBD-rich cannabis oil with either a 6:1 or a 20:1 ratio of CBD to THC significantly reduced caregiver-reported spasticity compared to baseline within the same treatment group. Regarding safety, primarily mild to moderate adverse events were observed during treatment with nabiximols compared to placebo, and the most common adverse events were retching, nasopharyngitis, and poor sleep quality. A numerically higher incidence of severe adverse events occurred with nabiximols compared to placebo, and 3 patients experienced hallucinations while receiving nabiximols, with one of these events being serious as it led to a suicide attempt. Safety outcome details were poorly reported by the Libson et al. Trial. Somnolence and excitation were reported by 1 patient each in the 6:1 cannabis oil arm, and 1 patient in the 20:1 cannabis oil arm reported mood changes which improved after discontinuing their methylphenidate. 2 patients taking an unknown cannabis dose experienced worsening of previously controlled seizures. Neither trial was considered to be at a low risk of bias on a Cochrane rating scale per systematic reviews. The Fairhurst et al. Trial was assessed as having a low risk of bias on most domains, except for the incomplete outcome data and the other category due to caregivers measuring the primary outcome. Whereas the Lipson et al. Trial was assessed as having a higher overall risk of bias, carrying an unclear risk on all domains, except for the risk from incomplete outcome data, for which it was considered to be at low risk. So in summary, we reviewed evidence from 10 experimental trials, including 6 trials of adults with SCI or SCD, including 201 total patients, a trial including 59 adults with ALS or PLS, 1 trial of 41 adults who had a stroke, and 2 trials including 242 children, primarily with cerebral palsy. Overall, mixed results were observed for the treatment of spasticity with the studied cannabis-based product. 4 of the 6 trials among patients with SCI found a significant result for at least one of the measured spasticity outcomes, and 1 additional trial exhibited mixed descriptive results. A beneficial effect of nabiximols on spasticity was observed for at least 1 outcome among adults with ALS or PLS, but not adults who had a stroke. 1 of the 2 trials of children with cerebral palsy found reduced spasticity with CBD-rich oils, and none of the 4 studies that evaluated changes in spasm frequency found a beneficial effect from nabilone or nabiximols compared to placebo. Although safety outcome details were underreported by many of these trials, generally it seems that the short-term use of the studied cannabinoid-based products was associated with primarily mild to moderate adverse events. Notably, in the trial among children, nabiximols was associated with retching, and 3 patients experienced hallucinations. The quality or risk of bias was assessed by a systematic review for 7 of the 10 included trials, and only 1 of the trials was considered to have a low risk of bias. Others had an overall unclear risk of bias or were of poor to fair quality. Overall, the included studies are limited by small sample sizes, quality concerns, short durations, and significant heterogeneity. Due to the large magnitude of heterogeneity and variability in the sources of that heterogeneity between trials with other similarities, I can't make firm conclusions about the impact of a particular source of heterogeneity on the differences in the efficacy results. Within the report and on this slide, I do discuss some of that heterogeneity. Notably, it's possible that differences in the nature of the spasticity across the different studied conditions or within or between trial differences in what was considered spasticity could have affected the efficacy results, particularly since there are different definitions of spasticity reported in the literature, and many of these studies did not rigorously define it in their study population. The degree of concurrent pain among trial participants could have also affected study outcomes, since pain tends to worsen spasticity and vice versa. All trials except for 1 appear to have allowed patients to continue most other medications or treatments for spasticity, which could have affected the ability to detect a change in spasticity if there were changes in the other medications, or if there's a ceiling to the antispastic effects when cannabinoids are added to other medications. I also noted that there was significant variability in the spasticity outcome measure that was used across the trials. And for trials that used the same outcome, there was also variability in how the outcome was measured. For example, whether spasticity was measured at only the most spastic muscle group or averaged across multiple muscle groups. Finally, changes on the modified or original Ashworth scales were a primary outcome measure for 3 trials that found a statistically significant result favoring the cannabinoid. And some consider these scales to have poor inter and intra-rater reliability, particularly for the lower extremities. Regarding comparisons to other systematic reviews, no single systematic review from the literature search included all 10 of these trials. 1 systematic review that included experimental and observational studies of primarily poor to fair quality concluded that cannabinoids might reduce spasticity in patients with SCI in the short term, but the investigators were unsure if the magnitude of the reduction in spasticity was clinically significant. Some other SRs included trials in other populations included in our review, and they concluded there were too few trials to make conclusions about the effect of cannabinoids for spasticity in patients with SCI, ALS, or PLS, and cerebral palsy, because they only found 1 trial each for each of those populations. A Canadian primary care guideline from 2018 addressed use of cannabinoids for cannabis cannabis or cannabinoids for spasticity, and weakly recommended that adjunctive medical cannabinoids such as nabiximols or nabilone for treatment-resistant spasticity in patients with SCI. They recommended against medical cannabinoids for disorders other than MS or SCI, or cannabis for spasticity of any disorder due to a lack of evidence. Guideline authors differentiated spasticity from spasms and stated that their recommendations do not apply to the treatment of spasms. Currently, the Utah's CRRB's guidance for treatment of MS includes a graded statement about patients with SCI with the conclusion that there is insufficient evidence, as shown in the middle of this slide. I believe that this statement is based on the conclusions from the 2017 National Academies report, whose authors concluded there was insufficient evidence since they didn't review the details of evidence from any of the patients with SCI. If desired, the CRRB may consider revising or developing graded conclusions and guidance about the treatment of spasticity and spasms among patient populations addressed by this review. Such information could be incorporated into a new guidance document or added to the prior guidance document for MS. I suggest creating separate conclusions for different populations and outcomes. Using the National Academy's evidence grading system, it's my opinion that experimental evidence is insufficient for the treatment of spasticity in adults who had a stroke and children with cerebral palsy or traumatic brain injuries. Overall, I feel that the evidence for treatment of spasticity with cannabis-based products among adults with SCI or SCD and adults with ALS or PLS could be considered limited. For the treatment of spasms among adults with spasticity or neuropathic pain due to SCI, ALS, or PLS, or stroke, evidence for treatment of spasms with cannabinoids is insufficient. If the CRRB decides to draft a guidance document, they should consider supplementing any graded conclusions with additional details about the characteristics of the experimental evidence, such as details about the patient population and study design. Examples of some of those considerations are listed on this slide. So that is the end of the presentation. I know that was a lot of information. Thank you for listening, and please let me know if you have any questions.
I feel like giving you an applause, Lauren. That was great. That was really, really good. Any questions for Lauren?
I have a couple. Lauren, in the studies when they vaporized cannabis, was that vaporizing the plant directly or was it an oil? Do you know?
I believe it was vaporizing the plant directly.
Yeah. Okay. And then the other thing is, it looks like there was fewer adverse events with those who vaporized over oral administration. Is that my understanding from the report generally?
Well, there was only one trial with vaporized cannabis, and it was only for a single day, and they underreported information about safety. So I don't think there's enough information to make.
No, not for a single day, no. Okay, that's all I have.
So to the board, any other questions for Lauren and her presentation?
Great presentation, really.
Thank you.
Yeah, as always, Lauren, Dr. Heath, I really appreciate your thoroughness in that review. And I think what we usually do now is consider her proposals and then vote on them at the next meeting. So I like her, I'll start that discussion. I like her proposals because as a clinician treating patients, I think it would be helpful to separate some of those disorders and to separate spasticity from spasm. That, like Lauren pointed out, those terms are often used interchangeably and they're not necessarily the same thing. And so I think this type of change or another guidance document would sort of lay the foundation for opening up that type of, discussion and maybe when new evidence emerges, we already have this foundation on which to build. Meaning we have great guidance document for MS. It would be nice to have a guidance document for muscle spasticity as it relates to spinal cord injury, ALS, PLS, as she has outlined. So, and again, the evidence is either insufficient or limited, but that again could change in the future if we get some new studies that build upon that, because you could tell from her presentation that, gosh, she spent more time talking about the limitations of the studies than the outcome, than the than the data. There are so many challenges with studying this stuff. But that doesn't mean it can't change in the future. So I want to propose that we send this out to the board, Sarah, as a offline work, and have the board members review that presentation and the research, and then next meeting vote on her proposals.
May I ask one more question of Lauren, please?
Yes.
I was just curious if in your readings you found anything for the cannabinoids other than CBD or Epidiolex in relationship to refractory onset epileptic spasms, because that was a category. It's a highly specific category, but it's not really addressed in a lot of the literature that you find online. And I know in recent years, really since about 2020, with all the synthetic and purified forms coming out, there's been some open label studies with Epidiolex for this particular epilepsy related condition. So I didn't know if any of the other, if cannabis itself or other cannabinoids have been evaluated as well. Because I couldn't find it. That's what.
I think my search wouldn't, I wouldn't have included those studies.
Okay.
So if they are out there, I didn't review them, so I can't speak to that, but I could search for that evidence to see if I could find anything.
I think that's one area where at least the purified cannabidiol products are being considered as adjunctive therapies. So it may be worthy of at least a search.
Cool. Any other questions for Lauren? Okay, so is everyone in agreement of reviewing those proposals for next time? Sound good?
Yes.
Awesome. Okay. So I don't know. So now Mike has joined us. So I want to get to the discussion on THC acetate. Perhaps we skip the patient assessment screening tool till after. I know
Yeah,
Mike
sounds
has to
good.
go. We'll reverse agenda items 4 and 5, and unless 4 is quick, I appreciate everyone's input on that. But let's move to agenda item number 5 while Mike is here, and let's talk about the THC acetate rule change. I know that many of you had input on this, and so, well, I don't know how to structure this discussion other than I hope everyone's aware of this emergency change proposal. And let's see, why don't we start with Brandon Forsyth, and then we'll move to Mike, and then maybe Russ, and go in that order of talking about this issue and what we need to consider as a board. So Brandon, can you take it away?
Yeah, absolutely. So as many of you probably already know, we found THC acetate in several products in Utah. It was most prominently found in, well, it was really only found in concentrates and vape carts because of our detection limits. And it was kind of surprising to us because supposedly this is a synthetic cannabinoid that should only be found in products where it was intended to be put. And so initially we thought there might be some kind of oil being brought into the program that wasn't produced here in Utah. People were trying to pad their products with outside oil, but that seemed like a very unlikely thing. And the more we looked into it, the more unlikely it seemed, because we were seeing this at multiple different processors. And it was brought to light because of a rule change that was made where we started testing concentrates for THCO acetate routinely. And once we found it, we tried to identify the source, and again, seeing that it was in multiple people's concentrates, it seemed unlikely to be contamination, intentional contamination. More likely it was occurring naturally. And so we started looking into it more and more, and found a group out in Colorado who indeed said that they had found it over there as well in all of the vape carts that they had tested in small amounts like we were seeing here. It seems that it's a natural byproduct of the decarboxylation / distillation process. Anytime you're heating up large amounts of THC for extended periods of time, there's potential to produce that. And so the limits that we had set would basically shut down any products other than flower in the state, because those limits applied to concentrates in general. So all these concentrates that are used to make gelatinous cubes, the vape carts, obviously, but any derivative products, tablets, tinctures, anything really, all of those have to be tested for cannabinoids first as a concentrate before they could be used to be put in any product. And so we would essentially have shut down the program entirely, not just remove vapes, if we had kept the rule as it was. So in order to keep the program functioning, we went to the board and told them that we needed to, all of our rules have to be run through the Medical Cannabis Policy Advisory Board now. We went and had a discussion with them and about what a reasonable limit would be, since this stuff was occurring naturally. We obviously had some serious concerns about THCO acetate to put it on the list of banned cannabinoids in the first place, primarily the formation of ketene gas when it is vaporized. And so we presented all that to the Medical Cannabis Policy Advisory Board, and then got input from them on what we could set as reasonable limits. We argued for some pretty restrictive limits, just because it is something we feel could be harmful to patient health, especially in, really only in vaporized form. And when it's ingested, like in a gummy, there's really no concern about it forming ketene gas. So we suggested some pretty low limits, and I think the board agreed with that for the most part, and came back with a limit of 1% of total peak area of THCO acetate in concentrates, and 0.5% in the total cannabinoid peak area in all other products. Well, they recommended in vapes, but in order for simplicity, we set it for all other products. But we don't expect to see it at anywhere near that in a gummy, obviously, because that's a severely diluted product. Same with tinctures and every other product other than those inhalable forms. So those are fairly reasonable limits that didn't fail a lot of products and would allow the market to keep moving. But we definitely have an eye forward to reducing the amount of THCO acetate over time. And we've been working with several producers in the state to get those amounts that we're finding in products lower. And we've had some pretty promising results thus far in optimizing your decarboxylation time in order to reduce the amount. But again, it can be found in any heating step. So really, producers need to be watching how long they're heating these products for. It's not uncommon, and I'm not just speaking in Utah now, but I'm talking broadly across the cannabis industry in the country and across the world, just to leave these things decarboxylate for extended periods of time, because it does take a fair amount of time to do it. And some people just leave it heating over the weekend sometimes. And that extended heating leads to degradation in cannabinoid concentrate, just like it would when you're cooking anything. Anytime you leave something heating over time, it's going to degrade. And so we see that in these concentrates. And we found one of these things to be THCO acetate, but there's likely many other compounds that are created through degradation of THC or other cannabinoids during these extended heating processes. And we're likely to keep finding other degradation products. But I think by working with the producers to optimize their processes and minimize the amount of time that heating occurs, we're not likely to see as many derivative products that are unintentionally created. Yeah, so at current state, not many products are failing those limits that were put in place, and we're seeing most products pass with well below those amounts. At this time, we've only had, I believe it's 8 products that have been identified and failed for THCO acetate at this point, and those were all vape carts or concentrates. And so that's at the time that we held the meeting with the McTab, that was about 4 to 5% of the total products. And the market seems to be moving now, and we'll be working again to eliminate it and reduce that limit in the future.
Thanks, Brendan. That was fantastic summary. Mike, do you have a comment or a input on that?
Questions and comments on it. Brandon, was the problem here that these weren't being tested before, that the reporting limit changed, that your assay changed? Because I thought that before we didn't think these things were occurring, and this rule's been in place for a while. So why did it come up now?
The rule had been in place for a few months at this point, but it had just become effective. And so we were starting to look at, you see in the chromatogram little bumps everywhere. And so at the time this all kicked off is when one of those bumps was finally identified as THCO acetate. And so once we started testing for it, we found it.
Also disallow anything that's not a naturally occurring cannabinoid, like Oregon, for instance. But I don't know about their internal testing policies around THCO acetate. And I didn't know that this was common. And most of my problem in researching this is there's so little actually published. You guys may be doing the testing, but it's not published. And so we just don't know how often is this occurring across the country in these other vape carts, and no one just had ever reported it before.
So that's a very good point. We reached out to several other states through CANRA, the Cannabis Regulators Association, and it seems that a lot of states have limits in place for things like THCO acetate and other synthetic cannabinoids, but they're not actually doing the testing for it. They don't have the THCO acetate as part of their standard testing panel, and so they're not finding it. You really have to be looking for it in order to find it.
Well, I
the rule
think
change was made to disallow these. We didn't necessarily know all the products it was occurring in because we weren't testing and quantifying and identifying it in all these samples. But is your opinion then, like in retrospect, this has been happening all along and this isn't a new problem they just introduced recently?
Yeah, I think we're going to continue to do this, like I was saying earlier, where we don't know everything that's in one of these THCO acetate concentrates. This isn't like the pharmaceutical industry where we're getting things that, 99.9% pure and then shipping them out. These things are, the concentrates that we see are somewhere between 70 and 98 to 99% pure THC. But there's other things in there, obviously, like CBD, CBG, THCV, all of these minor cannabinoids that are getting more popularity in some cases or being identified as potentially helpful by some groups. I don't know that I would say that that is super good data at this point, but there is some data out there to suggest that these are beneficial cannabinoids. But there's still probably a % or 2 in there that's just things that haven't been identified yet. And to me, there's reason to be cautious with some of that, even if we don't know things are actively harmful, like THCO acetate. As we find some of these things, we need to be keeping an eye on them and, look to the literature and hopefully get some pressure on to study some of these cannabinoids to see if they are harmful or potentially helpful. It's just hard to say at this point as we discover more and more.
excellent. Well, I want to just plug in for then the CANRA, the Regulators Association, for connecting states. And it seems like, again, I appreciate our Department of Agriculture for kind of leading the way, right? I mean, we're kind of one of the few states that's actually testing and putting forth some effort in regulation or safety. So kudos to you guys. Let's hear from somebody else. Russ and Misty, do you have any comments?
Well, my initial response was I'm against rule changes without some evidence to support safety. Obviously, we don't have that evidence. Is that what I understand? There's no testing that's been done to determine a safe level for the acetate.
Yeah, unfortunately, we just don't have those studies completed yet.
Yeah.
But as this is, as I
Talking
said,
about the
a common
THCO,
component
so
in
it's
all of these
interesting.
products,
Yeah.
it's
Then the question
been
I
part of
have
these
is,
for a long time.
and the question I have is, where were these limits derived from? I mean, if we have a history that we can look at and say, okay, you said that most of the products you're seeing are falling well below these limits. Is that what I understood you say?
Yeah, except for the concentrates and vapes, and the concentrates are used to make all other products. So if those failed, then we have no other products
Okay. But are
other than
they,
flour.
but you're not seeing many reach or exceed 1% total cannabinoid peak?
Yeah, most things are falling well below that 0.5%.
Yeah, I just wonder if there's a way to, if we don't have any research and we have to allow some of this in order to even make product, then is there a level that would be more conservative than this that would still allow products to pass, but be closer to a safety profile that we can accept?
If I can interject,
yeah.
there was a very useful slide that Dr. Forsyth presented to us at the McPAB meeting that really helped us or informed the decision for the levels that were indicated. And it basically broke down all the products currently available in the medical cannabis program,
right,
and what their concentrations were. And we really wanted to focus in on those products that had the greatest potential for production of this ketene gas. So in looking at those particular concentrates, that was what informed our decision to go with concentrations indicated.
Okay. So the presumption at this point, without further evidence, is that these concentrates are occurring because the products have been processed and concentrated from the plant, and it just reaches these levels as a part of that process.
And we do have good direct evidence for that now in our work with some of the producers, where we've actually taken samples at different time points through the decarboxylation process and seen the amount of THCO acetate rise very clearly.
Yeah,
it's almost a perfect exponential fit, or 1/x fit.
Okay.
So, this is really cool, Brandon. So I wonder, do you guys have a plan like in 6 months or a year? Because you reached out to the producers and advised them not to leave things cooking all weekend, right? Or maybe modify their
Here,
processes
listen
and
to this for a
policy.
sec.
And then perhaps maybe in 6 months or a year, we might see a difference.
Yeah, I think we've already seen reduction in the amounts and the concentrates we're receiving to test. And I think that'll continue and things will get lower and lower.
Awesome.
The producers, to be clear, are being very, obviously there's some that are struggling because they have products failed, but nobody wants this stuff in their products. And they've all been very responsive in trying to get their products clear of this. Nobody wants it there.
Awesome.
About what we do know about the toxicity side of this. So there exist out there, illegal vape carts, or I guess gray market vape carts that are just THCO acetate that you can buy, that people attempt to sell in states where there is no recreational or legal cannabis. And then they've deliberately created THCO acetate from CBD and then sold that as a way to skirt laws because it's not THC. People report, some adverse effects, but a lot of those really line up with the adverse effects you would expect with THC generally. And then this other one that's a little on the hypothetical side is the formation of that ketene gas, which may have been implicated in the E-Valley epidemic of the vape carts a few years ago, where people were getting all these terrible lung injury. And that was from vitamin E acetate, most likely. And
Right.
so the thought here is, could this THC O-acetate, if vaped, also have the potential to cause this lung injury syndrome? I'm not aware of any cases of that tied to these like only THCO acetate cartridges, and the amounts that it sounds like that we're talking about here would be very tiny compared to these other ones that are sold in this gray market area where that's the only cannabinoid, or the major cannabinoid at least, that's present in there.
I have heard from Oklahoma, one of the regulators down there that's part of CANRA, reported to us that they did find it in a product down there, and it was associated with a negative health outcome for not a patient, but just a citizen down there. And I believe that was published somewhere. I think, Misty, did you find more evidence on that one? I think you had found it somewhere.
Misty, you're
I
muted.
think you're on mute.
I apologize. Yes, I shared that at the McPAB meeting. I don't have that publication with me, but I could probably pull it up from the minutes of that. But it was just basically a case report of a negative outcome in a patient in Oklahoma. It was from their Department of,
Misty, or what was the problem?
and it was an emergency room visit. Let me see if I can find it.
Anecdotal reports online from different forums and communities of people saying the effects they experience from using it. I hadn't seen. I'd done a search. I guess it's probably been a month now or something, and I didn't find anything about any of the lung injury side of it. Definitely, plenty of people who get too high and panic or have other classic THC side effects and may end up in an ER. From some of those, but not anything that was necessarily thought to be specific to THCO acetate compared to regular Delta-9.
It was basically a advisory sent out from the Oklahoma Medical Marijuana Authority. It was in October of 2021, seeing a rise in the number of medical marijuana products containing THCO acetate. It says reports of dangerous side effects are increasing. And their quality assurance lab had confirmed the presence of the acetate in a particular product called Platinum OG Sugar. And they're asking patients to report any adverse outcomes associated with the product. But there's a number of reports from Oklahoma regarding negative outcomes, but they don't go into details about what those, and they talk about emergency room visits. They've actually issued a, there's just a lot of reports about the advisory.
And we don't know what level.
No, that was what we were initially searching for. And I don't think the amounts were quantified.
Quantified, yeah.
They weren't. I spoke with the CANRA member that's from down there, and it was only a qualitative test that they did on it.
Yeah, so we don't have good data.
Yeah. And unfortunately, I think this is exactly what's happening in Utah, is what needs to be happening across the country, where we're adding things like this to our panels, and we can get a good idea of what's actually in these concentrates and vape carts that are going out to patients and just consumers in other states where it's legal. Like, we need better cannabinoid testing and to get an eye on this, because there's still a lot of unknowns.
Well, for that reason, Brandon, I'm glad that you're participating in the CANRA and really contributing in a positive way. So if we have a couple more minutes on this topic, Dr. Chan, do you have any questions or comments? No?
No, I kind of agree with everything that people have said and asked, and the lung injury and that. So yeah.
Cool. Yeah, I think this represents a success in our protocols that we're developing. I know Dr. Viner had expressed some interest and input, and I would like to now give him a couple minutes as a special contributor to our board. If you'd like to make any comments.
Well, I think, hello, thank you. I think my concerns were answered by just listening to this. So I think everything I was concerned about was addressed. So I don't have any at this point. Good job. I think you guys did a good job. But eventually we should consider a organic chemistry panel to help, because they're starting to modify the rings in the THC. You know, first they're closing the B ring with, and now you can see they're modifying the resorcinol ring with the acetate. So I was just worried about the public health, safety, and harm that some of these can do. But it was well explained, so thank you. No questions. Thanks for asking.
Perfect. Okay, well, again, I'm very pleased with this presentation, Brandon. Thank you so much for coming to our meeting today. On agenda item number 6, this memo to MECPAB, do we need to make a memo, or what was that?
So we have a memo created for the adverse events reporting system integration. And
Oh,
then,
that was something else. Yeah. Okay.
yeah, and then I think we just wanted to see if this was still something that we want to bring to MCPAB, and if we do, we can get it hopefully on the next agenda. But just wanted to see what the next steps were with this one.
Okay, well, let's close our discussion with the THCO acetate. Are there any other comments or actions we need to take on that?
Concerns have been pretty well addressed about, you know, what were the amounts of this and what are the next steps around it. So I think it's as good as we can do for the moment. And if our board becomes aware of any more safety data that makes this a more urgent concern at these low concentrations, then we can, you know, pass that along. And certainly if at the poison center, I start hearing people calling with certain questions, or we hear about another batch of E-Valley lung injury cases, and I'd let everyone know. But I think this is probably as good as we can hope for at the moment.
Yeah. And my concerns have been addressed at this point. It seems like we're just ahead of the science. So, you know.
And I just want to reiterate that at the MCPAB meeting, this was not a set in stone limit. As more information is attained, we're definitely going to keep an eye on the literature and adjust as needed for the safety of patients.
Okay. Well, perfect. Thanks again, Brandon, and everyone for your input. This was very educational. Let's move briefly to that patient assessment screening tool that we drafted. Again, I appreciate everyone's input. I loved everyone's editing. I agreed with everything. Now it looks so busy, it's hard to read.
Yeah,
but
I was thinking we could go through some of it, and then I'm happy to make the changes after the meeting. Just like if we want to go through the comments and see if we agree or if we have any issues on things, and then I can go and clean it up.
Okay. Why don't you take it away then, Sarah?
Okay. So I guess for this first one, do we want to go with chronic pain or do we want to use persistent pain?
Well, that was a good comment. The previous documents were changed to persistent pain. Chronic pain is a bit more of an older term, or a possibly more common term. I don't know why the term was changed to persistent pain, but if we want to be consistent with our other documents and the qualifying medical conditions, we probably ought to change it to persistent pain. Any comments on that? I think it was Mike who pointed that out, but Mike just dropped off, I think.
Okay, yeah, I'll just make sure that matches then. And then for this one, do we just want to keep or for these, do we want to keep everything lowercase for consistency?
Yeah, if Chen is, if Dr. Chan, if you're better at grammar, then I totally agree. That's fine.
All right.
Just stay consistent is all.
And that's why it behooves us to have more people with eyes on this document so it looks right.
And then do we want to add this in, just the addition of considering drug interactions? Are we good with that? Just quick check if yes.
I think so, unless there are any objections. I think we can just move down the list quickly. I think most of these were really good.
Yeah, I agree.
The only question I have is on the age and experience. What was the reasoning behind 30 years old as the age?
Oh yeah, so thanks for pointing that out. That was just my own opinion. Sorry, I didn't get back to that. We probably should talk about that. That was an opinion, not a, it's approved for what, 21 and older?
Right.
So we probably shouldn't put a number there. That's just my own opinion. I think that I think 20-year-olds, even though it's legal, I think they're subject to more impetuous use or less responsible use than older people. But I don't know of a better way to say that.
Yeah, it just seemed a little strange to me. I mean, most of the people I work with are 50 or older, but I wouldn't want to put 50 there either.
Right, exactly. I mean, this was just a clinical person talking like, oh, I've had tremendous success with people 50 and older with this stuff.
Right.
20-year-olds, I'm a little bit more hesitant because, you have that long-term problem of possible disuse or tolerance or dependence. So it needs to be, as a clinician, you should think that way, but I don't know what to put in this document.
What if you just don't put a age per se, but just put greatest success appears in older adults? I mean, something like that.
Or
I don't work with anyone in the 20s. Most of the people I work with are 50 or older, but I have known people who, have had issues in their 20s. So
let's just say something like greatest success with age and experience. Because we don't want to just designate older adults, and that definition is like, well,
right, that makes me sound like I'm old too.
Yeah. But as people age and as people gain experience, they tend to be more responsible with medicine or with treatments or with I don't know. They tend to have more problems too. So they kind of go hand in hand, but leaving it more general would be better than putting a number on it.
Okay, I appreciate that. Yeah.
Thank you.
Okay, and then I think Dr. Chan's comment is just like reworded a little better, so maybe I'll just insert that in.
It's a bit more specific.
Yeah. And same with that one in. Do we prefer this wording? Okay.
Sorry for the.
Oh, I think you're on mute.
Oh, sorry for the experience. Is there a way we can make that more specific? So, just because, are you saying life experience, medical experience? Just experience is to me a very broad term. And there's people that say, well, I started smoking at 9 years old and I'm 17 now and I have lots of experience. Like, what do you mean by experience? I would just define that, because in reading that, because I heard what you said, but I just think we should define it in the document so people understand.
So does your change address that better? What you edited it? Additionally,
No, I didn't even look at the experience, but when Dr. Russ mentioned it, I was just like, yeah, I still need help on when you say age and experience. So when you were defining it, you were saying experience with knowing their bodies, experience with
I'm just getting when you say experience, if you can define that a little better.
Well, it is kind of a intentionally vague term because it does include lots of things: life experience, experience with disease or injury or pain, experience with medication. I mean, it is hard to define specifically, but I wanted to express the idea that, yeah, I trust a 30-year-old more than a 20-year-old. They know more, right? I have more confidence in them being able to, because titration of cannabis is a lot more difficult than something else.
Yeah.
But to your point, yeah, some kids have a lot of experience with smoking stuff, and I'd call that, well, it's not necessarily a good thing, but I don't know. It is kind of vague, but I was hoping to it imply something.
Well, your point is taken, Matt, and that, you know, I've met a lot of people who in the 70s, they smoked cannabis, right? And then they take it as a tincture in their 50s or 60s, and they're having a completely different experience with it.
Exactly. And I don't know how to express that. That's exactly the point.
Yeah. I mean, the liver metabolizes that into 11 hydroxy, which is 4 to 5 times more potent than Delta 9. So they have a high that they've never experienced before, even though they smoked, you know, all day long in their in the 70s. So I think experience is how you want to say it, but I'm not sure if it's comprehensive enough, you know.
And partly it wasn't just experience with use and medication. It was really, in the 70s, they smoked it for fun. In the 50s, they actually need it for something, right?
Yeah.
They're actually using it intentionally for a disease state or a pain rather than just recreational. So I didn't know how to express that briefly and as well as being thorough. So
Yeah.
And maybe it's something we can think on a little longer. And if we have any updates too, we can always go back in and clarify.
because this is really guidance for a clinician.
Right.
This isn't intended to be universal.
I think the latter part of the paragraph actually helps clarify what you're referring to initially with experience.
Yeah.
You're talking about the familiarity with dosing, titration, managing side effects. And then you're talking about other experiences with potential addiction, abuse, and other problems that may contribute to this
So
disorder.
perhaps to Dr. Chan's point, is there a reason to separate those two paragraphs, age and experience or experience with other controlled substances? Should those be merged? Would that,
That might make it more concise to merge them.
because we
I
don't
think
want to
so.
focus too much on age. It is one of the factors in people's experience and well, whatever, but we don't have to.
I think that's what you're trying to say, and I just don't want very literal, you know, getting confused is all. Like, I totally hear and I agree with what you're saying. I just want it to transmit in the document.
Perfect. So but perhaps we combine those two, remove the word age. So, or I don't know. I'm open to suggestions.
Well, you could still leave age in the description, but take it out of the front because experience implies also age in some ways, you know.
And you do talk about experience in the next paragraph, so you could just
Yeah.
say age and take out add experience because you have experience, like she just said.
Right.
Maybe something like that.
Yeah.
Okay. Yeah. Well,
I
I
mean,
guess
I'm
yeah.
always cautious with extreme elderly senior people. So
Yeah.
I don't interpret that you're saying as you get older, it gets better and better. Would someone else interpret that with that sentence? I don't think so, but just something to think about. Would someone interpret that as the older you are, so a 90-year-old will do really fabulous with cannabis? I don't think that's what you're trying to say there.
No.
How about greatest success with maturity instead of age?
That's better than, yeah. I mean,
And again, I think like with who the target is for this document, I think doctors and prescribers will understand kind of what we mean with that.
Yeah.
Yeah.
good.
Okay. And then I like Dr. Chan's rewording of this, and I can incorporate that after I know we're kind of
Yeah.
running short on time. And then just looking at these being deleted, I think that makes more sense and makes it a little easier to read. So are we okay with removing these?
Yeah.
Yeah, we were trying to keep it simple and keep it to one page.
Awesome. Well, it looks like it's just one page, and I can work on incorporating the other small changes. And then when I send out the other documents, I can send this back just for a final review.
Perfect. Thank you, Sarah.
Mm-hmm.
Yeah. Good.
All right.
Okay, we're a little bit behind. Do we have time to look at that memo, or should we postpone that, or what's the
I guess just if this is something that we're interested in pursuing, I guess that's really where the conversation is. If we want to keep working on this, if we want to bring it to the board, if it's something we feel like we want to stand behind, we can also postpone it. I don't think there's any pressing urgency with it, but. And then just as a refresher, this was to bring this to MCPAB to talk about application programming integration between our EVS system and other databases such as the Office of Medical Examiner, Poison Control Center, Department of Public Safety, just to improve data reporting, which can be helpful in a variety of things. But
yeah, well, we've talked about this a little bit before. It's really trying to merge the systems or have them at least link up so that the databases could, well, we can help identify problems. And so if we're, well, I don't know if this is this in a final form where we could just vote on it and send it to the,
yep, I believe so.
how do people feel about this? The idea is we want to be able to, those systems, our databases collaborate so that we could help identify problems, side effects, or
If I'm understanding it correctly from when I read it last night, I think it appears to be just an attempt to improve communications between different departments.
right.
And I think that's always a positive thing.
Yeah. I agree.
Fantastic.
I agree.
Great. So I don't know if we need a vote on that, but it's been prepared, and I think we all are in agreement that we would like to improve communication between agencies. We just had a great example of how, you know, the Department of Ag is doing good work, and it only matters if they collaborate and communicate that work. So I think we're all for the communication. So
I will talk to MCPAB and just see if we can get it on their next agenda then. And then we might need someone to present it. Is there someone who would feel okay bringing that to them?
I'll be there.
I nominate Misty.
All
I may
right.
reach out with additional questions, but
Okay. And I should be in attendance at that meeting too, so I can also be there.
wonderful.
Great.
Excellent. Okay, let's move on then. Trevor, is Trevor here for a legislative update?
I am here. Can everyone hear me?
Yes.
Wonderful. Okay, I'll try to be brief, but real quick, I'm Trevor Eckhoff. I'm a policy analyst with the Center for Medical Cannabis. I also staff the Medical Cannabis Policy Advisory Board, but I'll just be speaking to you real quick on the two large medical cannabis bills from this session, SB 233 and HB 389. And as you can see, this document's just a draft. We haven't quite released this yet because we're working on some plain language to make sure it's a really accessible document with, you know, really complicated legislation. But we've split it up between, you know, for patients, providers, licensees, and then others if applicable. But let's dive right in. And feel free to ask questions at the end, or if you have a burning question in between, I'm happy to try to answer that. But for patients, 2 big changes. Patients can buy 2 new dosage forms, which will be suppositories and a new form of edibles. The law specifically states a soft or hard confection that is a uniform rectangular, cuboid, or uniform spherical shape, is homogeneous in color and texture, and each piece is a single serving. So think about homogeneous confections made of sugar or syrup that all appear in same color, same texture, in a homogeneous shape. Number 2, patients can order medical cannabis via delivery to their workplace. They can't deliver it, though, to a community location, which is defined right here as a school, church, public playground, public park, etc. But previously, patients had to have a designated address, typically a home address or a long-term care facility, and now they could theoretically have it delivered to their workplace. Changes for providers. So limited medical providers, in addition to qualified medical providers, these are those who aren't registered with DHHS, but are able to recommend medical cannabis for up to 15 patients. They will be able to petition the Compassionate Use Board. Qualified medical providers can petition the department for a purchasing limit waiver. There's the 28-day purchasing period limit, which is 20 grams of concentrate or 113 grams of unprocessed flour. A QMP will be able to petition the department to increase that. And there's 3 criteria. They must have a terminal illness, have a life expectancy of 6 months or less, and needs the waiver for palliative purposes. That's how the law is stated. Next, qualified medical providers and the clinics that they're employed at can engage in targeted marketing. DHHS was given some rulemaking authority to decide what the standards will be for that. And I believe the department has 180 days from the implementation of the legislation to decide those rules. But I assume we will be communicating some of those potential rule changes with the Policy Advisory Board. And then finally, those same QMPs and clinics can be penalized by DHHS should they violate those advertising restrictions, which are to come in rule. All right, next, for licensees, medical cannabis companies can't use anti-competitive behavior. There's a very long definition of it in the bill, but primarily it speaks in letter and spirit to colluding to try to dominate the market, buy up other licensees, pressure licensees to sell, and again, a long definition. But moving on, the newly named Cannabis Production Establishment and Pharmacy Licensing Board will be able to review and approve location change requests for pharmacies. There's criteria as well, such as will this increase patient access, reduce costs for patients? So the board can consider some of those factors when looking at a location change. Let's move on here. So processors will also, those who manufacture the products, will be able to engage in targeted marketing. UDAF, Department of Ag and Food, has been given administrative rule authority over that as well. So those rules are to come. And finally, cannabis production establishment agents, as well as all owners in the industry. Previously, the restriction was for those that work in the production side or are owners of any of the types of licensees. They couldn't have ever been convicted of a felony at the state or federal level. That's been reduced now to 10 years, at least within the past 10 years would disqualify you. But this has made it even across the entire industry. Now, all folks that work in the industry, regardless of it's the pharmacy, the cultivation, the processing, or the owners, have now that requirement. Just a felony conviction within 10 years would be disqualifying. And then for others, 2 notes. The bill clarifies access to the EVS for law enforcement officers. Specifically, it says a law enforcement officer can only access if it's for the administration of criminal justice, which again kind of has a long definition about like apprehension, detection, etc. But it's presumed to be reasonable law enforcement duties. and otherwise EVS is not to be accessed by officers. Finally, there's another very lengthy section in the bill that talks about political subdivisions, the states, cities, etc., needing to have a written policy on employees who are medical cannabis card holders. And the bill says essentially that any of these political subdivisions or the state must treat medical cannabis like they would in a disciplinary manner with other controlled substances. Okay, moving on to the next bill, House Bill 389. This set a pharmacy ownership limit to 30% of the total licensees, rounded down in a whole number. So for example, and it's listed here, if there are 16 pharmacies in the state, you could only have 4 of those pharmacies under your ownership. Next, Department of Ag and Food can now approve what's called a closed door medical cannabis pharmacy. These would be locations that only specialize in delivery. And the bill says up to 3 can be opened until July 2027. Past that, it appears that there is no limit, although I'd have to double check on that. And only 3 of these pharmacies will be allowed in counties of the 1st and 2nd class. So along here on the Wasatch Front, there'll be limited numbers, up to 3 of those closed-door pharmacies. And finally, the bill clarifies that a pharmacist in charge is the person who determines which products the pharmacy is going to stock. There's a last thing related to our policy advisory board, which is that the board chair and vice chair, one of those roles has to be a DHHS appointee. 6 of the folks on that board are DHHS appointees. 3 are from Department of Ag and Food. But the bill says at least one of those seats has to be from DHHS, and that those elections for that chair and vice chair positions will be annually. And finally, that's it. There's also HB 534, which I expect Dr. McKiff to speak to a little more. But that's my presentation, and happy to answer any questions I can.
Thanks, Trevor. Any questions for Trevor? Well, thank you, Trevor. That was very succinct and informative. I loved that. That was good. It seems like there are a lot of minor changes that's going to add some flexibility to the industry, and some other changes that will be for safety and restriction to keep it appropriate. So that was good. This last one, I don't know a whole lot about the House Bill 534, other than this board. The duties of this board aren't going away, but it's going to be transitioned to the University of Utah Center for Medical Cannabis. So rather than being administered by the Department of Health, the research arm or emphasis that this board typically deals with is going to be assumed by the University of Utah and their resources in research. And like Dr. Heath, she's employed primarily by the University of Utah, correct?
That's correct.
Yeah. So anyway, it kind of makes sense that a research institution such as the U of U would assume the duties of this board, even though it will continue to function, I think, much the same way, because it will want not only researchers, but clinicians such as myself involved. I'm sure that they will have some sort of similar balance, but they will have control over that rather than the Department of Health from starting in 2026. So we still have 2 more years to function. But as it was evident today with the research is ongoing and needs to be. I mean, it's like we're still doing rather rudimentary research in cannabis because of all the problems associated with its research, homogeneous patient population and a homogeneous product. And like, we don't even have that yet. It was astounding the number of biases and inconsistencies in the research, as good as people are trying, it's astounding to see the variability still. So hopefully it will continue to improve, and this board under a different name and authority will still provide ongoing benefit to our community in this effort. So that's all the explanation I have about that. Okay, Sarah, do you have an education and research update?
Yep, I have a couple. So the first is that we had sent out a survey to QMPs back in December, I believe it was, just to see kind of what conversations they're having with patients and what resources they're providing. So we published those results on our webpage, and I'll put that in the chat so people can go view it. And that'll also be in our newsletter. But I thought that was kind of interesting just to see kind of what QMPs are talking about with their patients and their backgrounds. And then we have an upcoming meeting with Rich through the Center for Medical Cannabis, and that'll be on April 23rd from 9 a.m. to 10:30 a.m. There will also be some information about that in the newsletter, but that'll be to discuss the legislative updates and our new system rollout for the electronic verification system. So just kind of a place to answer any questions and to go over some upcoming changes so that we can all be on the same page. And then there's a Parker Parley's education seminar that happened last month, and it was on harm reduction and cannabis and strategies for safer use. And I felt like there was a lot of good information that came out of that. So if anyone's interested, that's on the Parker Parley's website, and that'll also be included in our newsletter. And then our newsletter is going out next week. So if anyone wants any information, that'll be coming out soon. And then Dr. McKiff and Rich both have a upcoming presentation, I believe in May 16th, from 2:30 to 4:30 at the Ogden Surgical Medical Society. So just want to give some information about that. And those are all my updates.
Thank you, Sarah. Again, I'll comment. This board is named the Cannabis Research Review Board. So we review research, but I think it's just as important to educate. Just like we talked about it earlier, if we do all this research but don't communicate it or teach it to anyone, then it's useless. And so I hope that as the University of Utah takes over this board, that they find other mechanisms also to disseminate this information and teach. I think that mission, it's not expressed in the name, but it's really ought to become a bigger part of what we do somehow. But okay, any questions for Sarah? Excellent. Everyone's just doing such an amazing job today that we'd have very few questions. Okay, so last item of business before we get to comments, board transition. So besides the transition to the U of U in 2 years, we still have to transition leadership. And so that will come up in June. Starting July, we will transition to a new board chair and vice chair. We've had I think it's in our bylaws, but the system has been that the vice chair will then take over the chair's duties, and then we need to elect a new vice chair. And we will need to do that at our next meeting in June. Our vice chair currently is Michael Moss. So starting after the June's meeting, we will transition for him to assume the chair duties, and then we will need to vote on a vice chair. So in the interim, we'll probably do this offline, accept nominations for vice chair. So if you want to nominate either yourself or nominate another board member for vice chair, please email Sarah and myself? Would that be the protocol, Sarah?
I think so. That sounds good.
So email nominations, and then we'll or interest, and then we'll vote in the June meeting, which is only 2 months, right? So we decided to do a June meeting for that purpose. Instead of just a quarterly meeting every 3 months, we decided to do a June meeting. Do we have a date for that, Sarah?
I don't think we do, but should we just keep it with the second Tuesday of the month? I think that's
Let's do. So the next meeting would be the second Tuesday in June. I hope that doesn't conflict with anything major. That would be June 11th.
That's the 11th, yes.
June 11th. So
Looks
that's
good for
like,
me. Yeah,
I'm sorry.
it's good for me.
Great. So let's plan on that, and we'll make a transition in leadership, and then that leadership team will probably set the agenda for the next year as far as content. And we have lots of good ideas and lots of things that we've addressed. We have some still on the docket, I think, right, Sarah, of our
Yep.
topics, but they'll set the agenda for the next year after that. So, okay, we're catching up. We're only 1 minute behind now, so we can move to board comment. 5 minutes for the board to bring up anything they would like to discuss. Well, sounds like we've covered everything we need to cover today. So then we'll get ahead of schedule now. So we can open up for public comment. If there's anyone, we have instructions for that to remind everyone. If you're attending this meeting and would like to make a public comment, you're invited to do so now. Please use the raise your hand function on Zoom and you'll be called upon in order. You have 2 minutes to make your comment. Please state your name and any affiliation that you might have, and then please share with us your comment. So we will open that up now. Sarah, if you would mind managing, the clock and the comments.
I haven't seen any so far, but if you would like to make a comment, just raise your hand or unmute yourself. Oh, doesn't seem like anyone's raising their hand.
Well, this is good. Maybe we've said everything that needs to be said. Well, again, I would like to thank everyone for being here. Again, I think this is a valuable effort to try to collaborate, research, and clinical experience, and then provide education about this very important topic. Advance the cause of medicine and serve the public health, right? So this is it's a noble thing to give people of your time. So I appreciate the time that you've spent in being here and contributing. And so with that, I'll call for a motion, unless there's any further discussion, a motion to adjourn.
I'll move to adjourn.
And I'll second.
All right, we have a motion, a second. Any discussion before we vote? All right, all in favor of adjourning this very informative meeting, please indicate.
Yep.
All right, thanks everyone.
Thank you.
Thanks, Sarah, for organizing the minutes.
Yeah, thank you guys.
Have a good day.